Hey y'all, welcome back to another episode of the Ashleigh Williams Show, and I'm so excited about today. So on my personal social media, I share a lot about my journey with Crohn's disease and endometriosis and egg freezing and all those things, and I always get tons of questions that I am not equipped to answer. So I thought I should bring my fertility doctor, who is the best doctor ever, Dr. Monica Best.
Thank you so much, Ashleigh, for having me.
Yes, I'm so happy to have you. So to go into a little detail, you know this, but I was diagnosed with endometriosis in 2016, my senior year of college. I was driving back to school and I could barely drive the car. That's how they found it. So I've been managing it, had the surgery, been managing it, not taking the medicine because it affects your hormones, and some days I would just cry or be sad. So it's like a lose-lose. You take the medicine, you pick up one thing, you don't, you make it worse. And so I got to a point where my goal is to be a mom one day. I'm still bought into the old school traditional lifestyle. I want to be a mom and a wife. That's so me. So if my endometriosis gets to that point, and I don't want to scare people, that's not everybody's fate, and it might not even be mine, but to make sure that I put protections in place, I thought that I'd go through the egg freezing journey. And when I Googled, because I found you on Google, everybody's like, Dr. Best, Dr. Best, Dr. Best, Dr. Best. So I'm just so grateful that you're walking with me on this journey.
Yes.
So tell me about you.
Who are you? How'd you get here? So, Dr. Monica Best is my name, and I am a board certified OBGYN and reproductive endocrinology and infertility specialist. So, basically I help couples and individuals build their families. Yes. I also spend a good portion of my time helping men and women primarily preserve their fertility. I also help couples who are same-sex build their families as well. So, there's a lot of things that I do just to help, like you said, walk with people on whatever journey they're on, to ultimately help them build the families that they want to have.
I love that. How did you decide this area of practice as opposed to what's my tummy doctor? What's that?
Probably your GI specialist.
Yes, right. Why did you choose GI or something?
So, I, from a very young age, I feel like this is just a calling. I feel like it's very difficult to do this because it is a lot of, just like walking in people's shoes. And, I feel like in order to be a really good physician, you have to be very empathetic and, really have a passion and a love for people. And so I knew from a young age that I wanted to help women from adolescence to menopause, understand their bodies, live their best healthy lives. And so that's what led me to OBGYN in the first place. Nice. And so I thought, my best life is going to be being an OBGYN and, helping young women and building those relationships in early adolescence and carrying those on into menopause for my patients. And then towards the end of my residency in OBGYN, I was introduced to the field of reproductive medicine. And it is just, as you can imagine, a very fascinating science behind it. Yes. And so I just fell in love with the science, the technology of it. And then the other thing that really drew me in is that it is a very unique time in people's lives when they're wanting to have and build their families. And, just being a part of that unique time and being on a journey with my patients during that very powerful, important time in their lives, really drew me into the field. And so, it was another way to help empower women, but also helping them build families, and that being very comprehensive in what I do in terms of just helping really all people that want to be parents get to that point.
I I love that. And I feel like it shows in the way that you care for your patients. Like, obviously you're interested because it's an interesting area to study, but the empathy is not lost on me. Like, I have seen my share of doctors and nurses so to just feel safe in a very tricky area. Like, okay, at the end of the day, I know it's expensive treatment and she should be compensated well, but I can tell you're not just doing it for those reasons. No, and I appreciate you, and based on your reviews,
not at all.
All of your patients appreciate you.
Mm-hmm. I mean, and it just, for me, I learn a lot from my patients too. So, I mean, it really is like, I give a lot, but I also get back a lot. And, it's not always easy,
no.
As I'm sure that you have experienced.
Yes.
But going through some of those challenging times, being in a position where I can encourage people to keep going, and then also relishing in their success, and seeing what we do can bring life, is, really, this is how I know that this is my purpose. This is where I'm supposed to be.
And we talk a lot about, I talk a lot about my purpose and figuring out what that is. So to see you say that you do discover where it is, and living in it can be a very fruitful experience, and not always like, oh, I gotta go do this today, but you can really enjoy what that looks like.
Oh, absolutely. And sometimes it is hard. It is challenging. It is not enjoyable in the sense that, not everybody has a straightforward path, right? Yes. I want to be able to help everyone. And I think what's so nice about being in this field in 2024 versus 10 or 20 years ago is that we have so many resources at our disposal, right? Yes. We have options. We have, the ability to preserve our fertility when we know that things are just going to get tougher as we age. Yes. We have the ability to, utilize donor egg in situations that require that. We have the opportunity to use donor sperm, surrogacy. So we just have so many ways in which we can help people build families in spite of some pretty significant challenges.
Yes, I definitely want us to go into that, but I think one interesting thing that'll help tell the story of why you show up the way that you do is you have personal experience in this area. So if you don't mind, share with us what that looked like for you.
Yes, of course. And thank you for asking, because I think, as young women, sometimes we are reticent to share our stories. And I think sharing our stories, sharing our struggles, sharing our fears, sharing our triumphs is going to help somebody else, right? It's going to help somebody else to see, okay, well, she's experiencing something similar to what I did, and look at how she came out on the other side. Or look at the resources that are available to me to help me or help other people that I love kind of get around some of those challenges. So, I was already in the field, and I was probably a first-year fellow at Emory.
Nice.
So during my fellowship, we have to do the fellowship in order to get the appropriate training in reproductive endocrinology and infertility. And so I was a first-year fellow. I was about to get married, and I thought I would check my AMH. AMH is a hormone that is secreted from the cells that support the eggs in the ovary.
Okay.
So the higher that number is, it's a blood test. The higher that number is, the more reflective that is of a good number of eggs in your personal egg bank. Okay. So it's kind of like a nice little spot check where we can see, okay, how many eggs does this patient have to work with? And I did my AMH, and my AMH was low. Okay. So, we ideally want to see AMH critically greater than 1, optimally greater than 1.5. I think mine was like 0.7. Okay. So, what that told me is that I had a lower number of eggs. I think I was 34 at the time. And so the average AMH for somebody in that age range, 20s, 30s, is going to be around 2 or 3. So I was like 0.7. So, you know, what that told me is that, you know, I had a lower number of eggs than what I should have at that age. You know, the other parameter of ovarian reserve is egg quality, right? And so that's what I had going for me, is at 34, I had a reasonable egg quality, okay? Which means that the percentage of normal eggs in my personal egg bank was good. I would anticipate at 34, about 65% of the eggs are gonna be perfectly healthy.
Nice.
And so at that point in time, again, kind of just speaking, you know, about fertility preservation and why it's important, and the rationale is I knew I wanted to have at least 2 children. And so to see my AMH already low at 34 before I had even had 1 child made me worry about the ability to complete my family on the other side, right? Because as we get older, we're gonna have fewer eggs. As we get older, we're gonna have fewer quality eggs to work with.
Yes.
So it's harder to get pregnant, harder to stay pregnant as we get older. And so I knew at that time, you know, based on the low AMH, that I wanted to go ahead and proceed with fertility preservation. And I did that through creating embryos, because I was ultimately married shortly after finding out that my AMH was low. So I proceeded with creating embryos at that point. And so the benefit of that is being able to collect eggs at a time where I had as many eggs as I was ever gonna have, and had as many quality eggs as I was ever gonna have. And so I was able to create embryos that were good quality, that could be frozen literally forever, that I could tap into as I started working on my second child, which inevitably was going to be closer to age 40 than I would have liked.
An embryo meaning the sperm fertilized the egg.
Exactly. So I underwent the same process of IVF, where we give the injections for about 10 to 12 days to mature a larger cohort of eggs.
Yes.
We then collected those eggs in an outpatient, very well tolerated 20-minute procedure. And if we were just freezing eggs, we would just freeze the eggs at that point, okay? And again, the more eggs we have, the better the quality of eggs, the more likely we are to achieve a pregnancy with those eggs in the future, right? At any point in time in your reproductive life, right? And so what I did is I went through that same process. We collected the eggs,
Your mic is. Say something.
we collected the eggs.
Okay, I'm sorry.
Okay.
Yeah, we good.
We collected the eggs, and then we fertilized them with my husband's sperm to create embryos. Okay. And so we were able to freeze embryos. Okay. So freezing eggs, freezing embryos, equivalent, right? Freezing the embryos was helpful to me because I knew I was ready to become pregnant with one of those embryos, and then the ability to freeze any extranumerary embryos for future pregnancies was really powerful.
Yes, I love that. Thank you so much for sharing. I think walking through that process also gives viewers perspective as well. When I told people that I was going through the fertility preservation process and freezing my eggs, people are like, wait, what? Yes. First of all, what does that mean? Why would you do it? All the questions. So you hinted at it, but why is it important, or why could it be beneficial for you to start thinking about that earlier, even if you're not married and actively seeking to have a child?
Absolutely. So, I mean...
Start you back at absolutely. Mic check. Say something for me.
Absolutely.
That's good. And absolutely.
Okay. So absolutely, egg freezing is one of the most powerful ways in which we empower ourselves for the future, right? And the reason why is that we were born with all the eggs we're ever going to have. Over time, there's decline in that number. Over time, there's increased risk of chromosomal or genetic injury to the eggs that we have as we age. And so it is much harder to get pregnant and stay that way as we age, right? And so, you know, whereas our parents used to, you know, complete their families before age 30, right? They would complete their families before age 30. We are not in the same paradigm, right? You know, from a social perspective, women are waiting until later in life to complete their families, right? So the average age of first birth is usually sometime after 30. And we know that at 35, we see a very accelerated decline in our egg number, okay? We also see an accelerated decline in our egg quality, okay? And so we've kind of talked about this before in that at age 35, about 40% of the eggs are already abnormal, okay? And there are some women that have a diminished number of eggs even before age 30, right? And so, you know, ideally, again, before we get to the point where we are older and where we have some diminished ability to get pregnant and stay pregnant, you know, being able to proactively freeze eggs allows you that, for lack of better terms, an insurance policy.
Yes.
Right?
Yeah.
So we just don't know what other barriers we're going to have, in addition to the fact that we know diminished ovarian reserve is going to layer on top of any other challenges that we have to build our family. And so we don't want to just wait. And also, we want to also know where we are in terms of our ovarian reserve. I probably wouldn't have checked my egg count at 34 if I weren't
in the field.
And I weren't about to get married and thinking about family planning. Okay.
Gotta switch these batteries in this mic.
When I decided to go through my fertility preservation journey, everybody looked at me crazy. Like, why are you doing this? What even is it? Is it safe? What does it mean? So I feel like this type of treatment is so taboo in our community and at an early age. So why is it important or a good idea to start thinking about it early, even though you might not be at that point to starting a family?
No, I think that fertility preservation is one of the most empowering things I do, hands down, as an infertility specialist, okay? And the reason why is, again, my own personal journey, your journey, and a lot of other young women that, you know, again, we know that ovarian aging is happening. We know that, like, we as a society of young women are waiting to start our childbearing later. You know, our parents' generation, they were done with their childbearing by age 30, okay? So they were building their families at a time where their ovarian reserve was most optimal. They were less likely to have, you know, anatomic problems like fibroids or blocked tubes. They were less likely to have medical problems that precluded a healthy pregnancy or carrying a healthy pregnancy. So they, you know, we are a very different society. And so we know that we're always going to have ovarian aging that is going to overlap or be, you know, running in the background of a higher instance of other issues. And if we're not starting our family until age at 35 or even after that, we know that even at 35, 40% of the eggs are abnormal. And again, most of us are going to start seeing some decline in that number, which means that if we get pregnant at 35, 40% of the time we're going to miscarry. Okay? And so if we're dealing with a smaller than normal number of eggs, like I was at 34, 35, that's concerning for being able to complete my family goals closer to 40, which is when I would be thinking about having another child. Also, again, by the time we're 40, 50% of the eggs are abnormal, okay? And most women have some diminished ovarian reserve by that time. And so, you know, just putting ourselves in a position to be able to meet our family goals is so important. We also don't know what the future holds, like, right? So we don't know if we're gonna have, awful fibroids that preclude us from, being able to carry a pregnancy. And so if we're facing surrogacy, we want to be able to access good quality eggs. And if we're waiting until we're 41 to approach creating embryos and extracting eggs for the purposes of surrogacy, we're going to be less efficient.
Yeah.
Okay. And so we know that as we get older, as we have fewer eggs, it's harder to be able to stimulate the ovaries, to collect eggs, to create embryos. And so again, our efficiency with this process is lower. We also are more likely to have, again, we don't know what the circumstances are going to be, right? So, I've had patients, more recently too, that have, been so grateful that they have eggs on ice because they come back and see me, they're later 40s, their husband doesn't have a good amount of sperm. And so IVF in those instances is going to be the most efficient, and we know we can work with good quality eggs, which is going to drive what our success rates are with IVF if we need to access that treatment.
Yes.
Also, couples that, again, you might not know the partner you marry overlaps with you in a mutation that can impact your offspring. Well, with IVF, we can screen embryos for mutations that might create disease in offspring to make sure that we're placing embryos inside of the uterus that are going to be genetically normal. So we can screen embryos to identify embryos that are genetically normal, males or females. We can also screen embryos that might be impacted by a genetic condition to make sure that we're transferring embryos that are healthy and are unaffected. So there are just so many dynamics. In addition to ovarian aging, which is really the biggest issue, that IVF or that fertility preservation at a younger age where we can work with good quality eggs sets you up to be able to have more success with building your family later in life.
Right. And I agree. It's definitely an insurance policy, definitely giving me some peace of mind. And I think that's why we should start talking about it way more often. And we'll talk about some of the challenges to getting to that point of actually getting through the treatment. But if we can start having the conversation, I think that's better. So I'm just so glad that you're here.
I think raising awareness, especially, among women of color, because again, we don't talk about this as much. I want us to be open because also we're, if you look at the statistics, we are amongst the highest educated. We're spending a lot of time, on our careers and our education. We can't forget about the importance of making sure that we have eggs available to us when we're ready, right? When we meet somebody who's worthy of us moving forward and building a family with, that we can actually do that with our own eggs is really my hope for everyone. Even though I know I have options to do donor egg, but I don't want to I know that, everyone's first choice is to be able to have their own genetic child, and I want everyone that wants that to be able to have that opportunity.
Yes, I agree. And thank you again. I will not stop thanking you today. So we talked about the first set of issues, which are inherent to everybody, which is the ovarian aging. It doesn't matter how healthy you are, that is going to happen.
Doesn't matter, and I'll tell you, I have patients that are like, but I exercise, but I eat right. And I'm like, the ovaries haven't gotten the message. There is just a physiology here that we're beautiful on the outside. As women, we're like wine, we get better with age. Yes, we do. But the ovaries, again, it is part of just physiology that to date we haven't been able to alter or change. Right.
And so we have that, but for the women who struggle with other challenges like me, that could be endometriosis, PCOS, and I'll get you to explain those because I will butcher it. Cancer treatment. How does the journey look different for those of us, and what are some things in mind that you have when you say, okay, this patient has a different set of issues? What are you thinking about when you go forward and decide those treatment plans?
Excellent question. You know, the conditions you just listed are conditions that are, you know, are common in terms of their concordance with infertility and diminished ovarian reserve. Okay, so for endometriosis is basically where there is endometrial tissue that is outside of the lining of the uterus where it should be. Okay, and so when women with endometriosis have their menstrual cycle, that endometriosis that is in the pelvis can cause inflammation, it can cause scarring of the fallopian tubes, and predispose to infertility. Okay, and so if our tubes are blocked, we know that that is the space in which fertilization happens naturally. So what happens every month is you ovulate your egg, you release that egg is picked up by the fallopian tube, hangs out, waits for sperm to come and fertilize it 12 hours late, within that 12-hour period. If sperm doesn't fertilize that egg within 12 hours, that egg dies. The other thing is the cohort of eggs that were active during that month also die. The next month we've got another cohort. But ultimately, if fertilization can't happen naturally in the tubes, then we are really committed to IVF, right? And so those are patients where if we know that we are dealing with a challenge of blocked tubes early on, we want to get eggs that are of good quality, as many of them, on ice in preparation for pregnancy at a later time if they're not ready to have children yet, right? So we know that we want to be efficient when we get to IVF because we know we're going to need that to have our babies, right? So endometriosis also can impact the ovaries, can cause endometriosis involving the ovaries can cause ovarian cysts like endometriomas, which can cause, again, scarring in the pelvis and an impediment in that natural process of fertilization to occur in the tubes. Again, those are patients I can't stress enough. We want to get eggs on ice as soon as we can. Also, you know, sometimes the frequent surgeries that patients with endometriosis have to have can impact the ovarian reserve because we're operating on the ovary, sometimes removing normal ovarian tissue in that process. And so what we see is a diminished number of eggs in those patients with endometriosis kind of running alongside some of the structural problems. So we really want to have eggs on ice for those patients. Patients with PCOS, for example, PCOS is basically a metabolic disease. 10% of all reproductive age women have it, so it's really, really common. And so what this is the ovaries in women with PCOS produce high levels of androgens or male hormones. All ovaries produce male hormones, okay? Just women with PCOS, they produce more of them. And so what that does is it interferes with the signaling between the brain and the ovaries to make an egg each month, okay? And so if you're not making a mature egg each month, then it's really difficult to get pregnant, okay? And so those patients may require some infertility treatment along the way. So sometimes, again, having younger eggs, better quality eggs, more of them on ice for those patients is very, very helpful for their family planning because they know, hey, this is gonna require some intervention. If I'm not starting until I'm 35, I really wanna make sure I've got good quality eggs or embryos on ice so that I have a higher rate of, you know, completing my family when I get there.
Yes.
So there's options for everybody. Don't freak out.
There's always options.
Yes.
And then for the patients that are diagnosed, unfortunately, with cancer, we know that, you know, chemotherapy can accelerate loss of those eggs. And so for those patients, I really want them to, you know, continue with their definitive treatment. We usually get those patients in very quickly to get eggs on ice before they're exposed to chemotherapy. That can really reduce very significantly the number of eggs they have available to use after the chemotherapy.
Right.
Didn't hear that at all. Thanks for sharing that piece. So we've talked about why it is a good idea to start thinking about it regardless of what your issue is.
Plus, I think every woman should have eggs on ice.
Yes.
I mean, in a perfect world, everyone would have eggs, you know, and because I'd rather you have them and not need them than the other way around.
Right. And so walk me through the entire process of IVF end to end. We talked about the freezing, which you'd stop there if it's just preservation. But if you are ready to deliver a child into this world, what does that look like?
So it's
Got 3 minutes. What does that look like?
okay. It's identical, the beginning stages of that. So what we do is we're going to be giving injections that are similar to the FSH your brain produces to mature your natural egg over the course of the cycle. What we're doing is we're recruiting a larger number of those eggs over the course of the cycle, so 10 to 12 days of injections. The average patient has 3 to 4 ultrasounds over that period of time, so we can measure the size of the follicles and your estrogen. Then we collect the eggs in that outpatient 20-minute procedure that's very, very well tolerated. And then the lab isolates the eggs from those and either freezes the eggs by themselves if we're just freezing eggs. And what they're going to be doing is, in most cases, actively fertilizing the eggs to create embryos for those patients that are ready to achieve a pregnancy.
Perfect.
What I didn't realize is you were in the doctor's office getting an ultrasound every other day. I was like, my life is revolving around this process right now. So it is a huge time commitment.
It's 2 weeks though.
Yeah.
The way to think about it is it's really 2 weeks from the time of the start of injections to egg retrieval, you know? And so, and there's those 30-minute, you know, appointments 3 to 4 times over that period of time. So it's not awful, but I think it is initially kind of overwhelming.
Right, yes,
right?
that is the word.
It can be because there's emotions tied to all of this and, you know, just, you know, having to give yourself injections, which, you know, usually after the first couple days you kind of get used to it, but, you know, but it's a mental and a physical process that you just mentioned.
Yes. And what encouragement would you give to women who have to go through multiple rounds, or even they're just saying, okay, this is a lot, it's time to explore other alternative options?
Yeah, I mean, I think, you know, I feel like if you have, like many women do nowadays, if you have a benefit that is basically saying, here you go, so that you can build your family, I really try to encourage those patients to use that benefit. Even though sometimes mentally and physically it can be challenging to go through multiple cycles of IVF, and I acknowledge that. But I feel like, you know, for those patients, I'd rather you have as many eggs as you can muster from the benefits and the resources you have on ice before we continue to age and we know that things are going to become less favorable. So I just try to be a cheerleader. I did more than 1 cycle of IVF. You know, I needed more than 1 cycle, right? Because I had challenges in terms of egg number, in terms of embryo number. So, you know, I just try to, you know, get them to dig deep and keep moving. Yeah.
Coming so loud.
Okay. Shoot me though, girl.
That's okay. That's okay. That's okay. That's okay. That's okay.
Oh my gosh, that was so good. What was the question?
You just how do I help people keep moving, keeping going? Dig deep. Dig deep. Yeah. Just really dig deep. I mean, you know, again, think about it like a 2-week process, you know, and take a break if you need to, come back at it. Just don't wait too long, but take a break, come back at it. Gotcha. Right?
Can you hear it?
Why would she do that? All right, you gotta wrap it because.
Okay.
Last question. I know it's a very expensive procedure. So we talked about how some women have the financial benefit offered through some types of insurance or other processes in their jobs, but are there other benefits financially if you don't have that as an option?
So what I have found to be the most encouraging about, you know, kind of where we are today, and of course being where we are, and, you know, seeing companies compete for talent, is we have a lot of fertility treatment benefits out there.
Gotcha.
Even for fertility preservation only, and for things like surrogacy. So we are really expanding in terms of our access to care. But there are also financing benefits out there. There are also more and more grants, you know, as we raise awareness, as we talk about this more, as we understand how big of a problem infertility is, and preserving fertility, and what a challenge it is. You know, again, I've just seen the industry explode in terms of access and resources.
I love that. So we're talking about it more, which means funding comes with this awareness. So that's great. Thank you so much, Dr. Bess, for your time. I know we might have to have you back for a part 2, because this is such valuable information.
I am happy to come back, just because I think we need to keep talking and
Yes.
raising awareness. Yes.
So
Thank you so much. If you would like to get in contact and seek Dr. Bess treatment here in Atlanta, Georgia, you are with
Reproductive Biology Associates. So yeah, I'm here. I'm not going anywhere.
Yes.
So thank you so much for having me.
Thank you. Thank y'all for tuning in to this episode of the Ashleigh Williams Show. As always, we will be back next week, so don't forget to go be awesome today. So please don't forget to like, comment, and subscribe, and I'll see you next week.